I'd like to introduce our speakers for today. We have two speakers. Dr. Chris Bryant joined the University of Louisville School of Medicine faculty in the year 2000 and is currently a professor of pediatrics in the Division of Pediatric Infectious Diseases. She's also medical director for pediatric infection prevention and control at Norton Healthcare. She is the immediate past president of the Pediatric Infectious Diseases Society, the world's largest organization of professionals dedicated to the treatment, control, and eradication of infectious diseases affecting children. Dr. Bryant recently completed a term of service on the Healthcare Infection Control Practices Advisory Committee. This is a federal advisory committee that provides advice and guidance to the CDC regarding strategies for surveillance and prevention and control of healthcare-associated infections in the United States healthcare facilities. Dr. Bryant has relevant relationships as an investigator on clinical trials funded by Pfizer, Gilead, and Enanta Pharmaceuticals to disclose. Our second speaker today is Dr. Gary Marshall, who received his medical degree from Vanderbilt University, where he also completed his pediatric residency. Dr. Marshall then completed his fellowship in infectious diseases at the Children's Hospital of Philadelphia. In 1989, he joined the University of Louisville Department of Pediatrics, where he's now professor of pediatrics and chief of the Division of Pediatric Infectious Diseases. Under Dr. Marshall's leadership, the Division of Pediatric Infectious Diseases has repeatedly been recognized for excellence in teaching and patient care. Dr. Marshall is a member of numerous academic societies and has served in several national leadership positions. He is credited with over 190 publications and is best known for his work in vaccine development, advocacy, and education. Dr. Marshall is the author of the Vaccine Handbook, or the Purple Book, a practical guide for clinicians, which is now in its 9th edition. Dr. Marshall has the following relevant relationships to disclose: a consultant to Pfizer, honoraria for service on Pfizer advisory boards, a research contracts with Pfizer, and a principal investigator on clinical trials sponsored by Pfizer. So welcome the two of you, and I'll turn it over to you.
Thanks so much, Dr. McDonald, and welcome to everyone. And thank you for joining us today to talk once again about COVID-19. As Gary and I prepared for this talk today, I was struck that it's been nearly 2 years since we had our first COVID-19 update. And there is still more to say. We are looking forward to giving you an update and answering as many questions from the audience as we can. So let's jump in. Gary, next slide. You've already heard my disclosures. Next slide. All right, so what's new since we met last? Well, Omicron, and you're going to hear a lot about that from Dr. Marshall. I suspect you have plenty of practical experience at this point in time, since there are more than 800,000 new cases every day in the US and 10,000 a day in Kentucky. Since we met last, there is new isolation and quarantine guidance for the general public. If you have questions about that, we can certainly talk about it at the end. We are still learning about the health effects of SARS-CoV-2 infection in children. You may have seen an MMWR released within the last week or so that described an increased risk of new diabetes diagnoses in children 31 days after their initial COVID infection. We also have new data about the effectiveness of COVID-19 vaccine in adolescents. There was an MMWR that highlighted that 2 doses of the Pfizer-BioNTech vaccine are protective against MIS-C. There was also a paper in the New England Journal of Medicine that identified that 2 doses of vaccine, this is in the pre-Omicron period, were effective against critical illness, ICU admission, and need for life support in adolescents. We still think that that protective effect will be seen with Omicron. We know that in Kentucky, immunization rates among adolescents and younger children are all too low, and Gary will talk to us a bit about that today, why we need to advocate for vaccine and what we might do to increase immunization rates. Next slide, please. I always like to give you an update about what's happening within Norton Healthcare, and depicted on this slide are the number of tests sent by month. Tests sent by some of you in this audience. The total number of tests is at the top by month, and in the red bars, you see the number positive. We are on track for a record month in January. Our percent positivity is running just over 40%. Next slide. And on this slide are pediatric hospitalizations for COVID-19 within our system. If you look at January, you might say, oh my goodness, what a big jump. I don't want to give you the wrong impression. Yes, we have a lot of kids who are hospitalized with COVID-19. Today, I think 23 of our admitted patients have a positive COVID test, but recognize that at this point, more than half of them are not being hospitalized for COVID-19, but they're being hospitalized with a positive COVID test, and they're actually here for something else. When I looked at the list this morning, we had at least 3 neonates in the first month of life who were admitted for fever. At least one of those had a co-infection that was probably driving hospitalization. We have children admitted for a variety of diagnoses who happen to be who test positive for COVID. I don't want to leave you with the impression, though, that COVID disease has gone away. We are still seeing, as we saw in December, as we saw in November, kids being admitted with respiratory distress, and even a small number of kids with respiratory failure. So COVID-19 is worth preventing. With that message, I will turn it over to Gary to give us an update about epidemiology and about vaccines.
Thanks, Chris. Can you give me a thumbs up that you can hear me? Okay, thumbs up, great. I wanted to just give a few disclosures before we go into this. It's kind of cumbersome when we refer to the vaccines by their generic names, or in the case of the Pfizer vaccine, its trade name. So in this presentation, we're just going to call the vaccine by the name of the manufacturer. And then you've also heard my disclosures in terms of being a consultant for Pfizer and having been a principal investigator on the clinical trial that is being done in young children. So we want to, our goal for this this afternoon is for you to understand the changing epidemiology of COVID, to explain the rationale for vaccinating children, to be able to answer parents' questions about the risks of vaccination, and also to judiciously refer patients for outpatient monoclonal antibody therapy. We'll get to that a little bit later. So these are the total, these are the daily cases, the running average in the United States. And you can see here in the green shading, the various waves that we've experienced. And this is pretty much something we've gotten used to, right? The original, this isn't even really the ancestral strain, it's the one that emerged from China and was able to spread in Europe. Then there was the Alpha variant, the Delta variant this past fall, and now Omicron. But I want you to appreciate the magnitude of the Omicron surge and the slope of the curve. So this is really just unprecedented in terms of how quickly this virus has spread. On the other hand, these are deaths in the United States, and you can see here that despite being so prevalent and spreading so quickly, Omicron seems to have resulted in fewer deaths. That's being said, this virus has killed more Americans than died in every single war cumulatively from 1900 until 2022. So as I alluded to, it seems like Omicron is less virulent. This is a plot of the case fatality rate. That is, if you get COVID, did you die? And you can see here that so far, the case fatality rate is much lower for Omicron. This slide shows the percent of COVID sequences that fall into the various variants that we've seen over time. And there are 3 countries shown. One is the United Kingdom, the United States, and then South Africa. And I think you can appreciate from here, just visually, how quickly these variants have emerged, beginning with the change from the ancestral Wuhan strain to the one that had a single mutation at position 614 in the amino acid, to the strain that originally infected the United Kingdom, which morphed into the Alpha variant. And then within a few short months, all the strains that were being sequenced were Delta. And now, again, all the sequences that are being found are Omicron. And you can see the same is being shown here for the United States. And this is a phylogenetic tree that, again, shows you the genetic distance between various isolates throughout the world. And it shows very clearly how these variants have emerged, beginning here with the branch of the Alpha variant, but in a separate branch, the Delta, which came up later. And then the red isolates here are the Omicron variant as of December 2021. So let's talk a little bit about the evolution of this virus, because this is what's really important to understand how the virus is able to change itself and to spread as it has. It all comes down to this spike protein, which by now you're very familiar with this. It is the viral receptor for the ACE2 molecule, which is on virtually all of our cells and in our blood vessels and in our lungs. And this is the protein that the virus uses to attach in humans. This is a computer model of the sequence of the receptor binding domain of the spike protein engaged with the ACE2 receptor. And the model looks at how well does that receptor binding domain attach to ACE2. And you see here in the first panel, the wild type, ancestral virus, the Delta variant, and the Omicron variant. And this number here, E total, is a measure of the docking energy between the RBD and the ACE2. And what the study illustrates is that as the virus has evolved, it has learned how to attach more tightly to the ACE2 receptor. But the virus has also learned other things. So for example, the Delta variant was much more capable of infecting human lung cells than the wild type virus was. The Omicron variant is 70 times more capable of replicating in bronchial epithelium compared to Delta. But fortunately, it is 10 times less good at replicating in lung tissue. So this probably explains 2 things. Why is it spread so quickly? It's because it's replicating to a much higher level in the upper airways than the previous versions did. But it also explains why this disease is less severe, because this virus doesn't replicate in the lung as well. One trait that both Delta and Omicron have acquired is the ability to form syncytia between infected cells, which was not a characteristic of the original strain. And this has helped the virus evade immune responses and replicate efficiently. But here's the thing that's really alarming, is the ability of the virus, based on evolution of the spike protein, to evade the host immune response. So here are the clever little monoclonal antibodies that were developed in the laboratory, specifically able to target epitopes on that spike protein. And you can see here in the blue with the Delta strain that the previous monoclonals that we used, this one is Regen-Cov, and this one is Bam-Edi, you can see that the ability to neutralize Delta was phenomenal. So this is the percent of virus neutralized, and this is the concentration of the antibody. And you can see here that 100% is neutralized at very low levels of antibody. But the red is the Omicron strain, and neither of these monoclonal combinations is able to do anything against Omicron. Now, fortunately, sotrovimab does have activity against Omicron, but notice the shift of the curve to the right, so that in order to get, for example, I don't know if you can see my little cursor there, but in order to get 50% neutralization of the virus, you need a concentration of 1,000 nanograms per ml, which was much more than you needed to neutralize the previous versions. Also, when you look at vaccinated sera, as well as serum from people who've been infected with COVID in the past, it's not very good at neutralizing Omicron. So here are several scenarios. These are folks who were immunized 5 months ago with 2 doses of Pfizer. And you can see here, this is essentially the same as percent neutralization, or the opposite of neutralization. You can see here that these sera do not prevent Omicron from infecting cells. What if you are boosted? So 3 doses of the Pfizer vaccine, and you can see here that we do get some neutralization, but it's not as good as against Delta or the D614G. 6 months after having had natural COVID, you do not have much neutralizing antibody against Omicron, and the same is true 12 months after COVID. But if you've had previous COVID and then you got a dose of Pfizer, 1 month later, you do have appreciable levels of neutralizing antibody. That is why it is important to vaccinate people who have had COVID in the past. So you can see it's all about the spike protein, except when it's not. So the virus has other ways of evading the immune response. So the alpha variant, for example, has evolved the ability to increase its expression of the subgenomic RNAs that code for these 3 non-structural proteins that are in the red box. Well, what do those proteins do? Those proteins shut down your innate immunity. So, for example, here you can see where the transcription of genes and the expression of interferon is inhibited by these proteins made by the virus. So it illustrates that the mechanisms of immune evasion are more than just changes in the spike protein, but can actually affect your cells in terms of their gene expression. So here's the thing, though. If I've just shown you that prior infection and even vaccination doesn't seem to be able to give you a lot of neutralizing activity against these variants, then why is it that vaccination is still very protective against disease? So you may still get infected, but you're very unlikely to wind up in the hospital, and you're very unlikely to die if you've been immunized, even if you're infected with Omicron. And this hasn't really been worked out for sure yet, but I have to believe it has to do with the other arm of our adaptive immune system, which is the T cells. And as you remember, T cells don't prevent you from getting infected, but they limit viral replication once you've been infected. And they do that by looking at very different pieces of the virus than what antibodies look at. And these are small peptides that derive from other proteins in the virus besides the spike protein. So I think that both prior infection and vaccination give us some measure of T cell immunity, which helps protect against disease, but not infection. So let's talk for a minute about the disease burden in children. Chris showed you hospitalization data locally. in some ways, we don't really even have to tell you about the burden of disease because you already know it. This is a study that was done in the UK that looked at 588 kids 5 to 11 and over 1,100 who were 12 to 17, looking at, well, what symptoms did you have? And you all are very familiar with this. It's headache, fatigue, fever, sore throat, anosmia, abdominal pain, and these symptoms last for a median of 6 days. In some cases, as long as 11 days. But hidden behind this is the burden of persistent symptoms. So in this study, also from the UK, they looked at 5 to 17-year-olds who were still having symptoms a month after the acute infection. And the coding here is the color, which the darker color shows you a higher proportion of kids, and the graph shows the days since onset of symptoms. So highlighted here in the red are the symptoms that really seem to persist: the anosmia, the headache, the sore throat, and the fatigue. When you look at data from the US, these are COVID hospitalizations per 100,000 broken up by age group in childhood. You can see here where during the Delta surge, we had an increase in hospitalizations. It hit a low point sometime around October, November, and then it started to go up again. And not surprisingly, it's the 0 to 4-year-olds that have the highest hospitalization rate. And that's largely because we don't have vaccination for them. Although we do have vaccination for the 5 to 11-year-olds, and they aren't being vaccinated for some reason. Importantly, if a kid is immunized, they are extremely unlikely to be hospitalized. There's, in fact, an 11-fold difference in the hospitalization rate between adolescents who are fully vaccinated and those that are not vaccinated. An outstanding question is, does every strain produce MIS-C, the multisystem inflammatory syndrome that follows COVID? These are national data. As of January 7th, there were 6,400 cases of MIS-C and 55 total deaths. And of course, the data have not been updated yet because you don't see MIS-C till a month after the COVID. So whereas, here we are with the spike of Omicron, are we going to see a spike in MIS-C that is proportionate? And I think that's an outstanding question. So if you look at morbidity overall and compare COVID to flu and invasive meningococcal disease and invasive pneumococcal disease, all three of those are diseases that we avidly vaccinate against. The average annual number of hospitalizations over the 2 years of the pandemic has been around almost 18,000. So that compares to almost 40,000 per year for influenza hospitalizations among children, but it's much greater than for pneumococcus and for meningococcus. If you look at deaths, this is average annual number of deaths. For flu, there are usually around 450 children who die every year. For meninge, it's 12. For pneumococcus, it's 11. And for COVID, it's been almost 400 over the 2 years of the pandemic. And that includes MIS-C deaths. So these are the color-coded vials for the available vaccine for children. I've tried to summarize. I mean, if you think it's been hard to keep up with all of this, try being a, quote, vaccine expert, because I have literally had to change these slides almost every day. And sometimes I've had to ask Chris Bryant to ask her little friends at CDC, can you explain to me what they mean by this? Because it's been impossible to track it. Here's the best I can do. For the primary series, it's broken up here by age, the 5 to 11s, the 12 to 17, and then the 18 and above. Under 18, we only have Pfizer. There's 2 different doses. There's the 10 mics and there's the 30 mics. They have a different volume to deliver that dose. The primary series is 2 doses that are 21 days apart. And you see here for Moderna, it's 28 days. For Janssen, which is not favored anymore, it's 1 dose. I do want to point out, though, that if the child is immunocompromised, then they are supposed to get an additional primary dose. Now, what is the difference between that and a booster? Or what is the difference between that and a 3-dose primary series? I have no idea. They're calling this an additional primary dose, and that can be given 28 days after you complete the 2-dose primary series. So for example, a 7-year-old with an immunocompromising condition would get doses at day 0, day 21, and then 28 days after that. And then they would be considered complete for that primary series. What are the things that qualify as moderate to severe immunosuppressing or immunocompromising conditions? Those are listed here. I won't go through them, but I understand that these slides will be available to you, or a handout will be available. What about the booster dose? Well, it's very clear that the booster does provide protection after the waning of immunity, and it also provides protection against Omicron. You know, one of the most interesting things about this is that all of the vaccines contain the spike protein from the G614. So it's the original spike protein. And despite that, they are still able to protect against the very mutated spike protein that we have now. These are data from Israel that showed that the effectiveness of the booster dose. So these are the recommendations for the booster dose. It is not recommended at 5 to 11. From 12 to 17, it is recommended. The dose is to be given at least 5 months after the primary dose. And that is the same interval for the boosting for the adults as well. The only exception to that is if you got Janssen, you get a single booster dose 2 months or more after the primary. Now, understand here that if we define your primary as 3 doses, you wind up getting 4 doses. So your immunocompromised kids who got 0, 21 days, and then 28 days later, 5 months after that 3rd dose, they will get their 4th dose, which is their booster. We're going to give age-appropriate vaccine formulation regardless of your size or weight. So if you are 12 to 17, you get the 30 micrograms. Under that, you get the 10. The dose is based on the child's age at the time of vaccination. We get a question a lot of times, well, after COVID, when can you get vaccinated? As soon as you come out of COVID isolation, you are eligible to be vaccinated. We don't recommend serologic testing to confirm prior disease or to make any vaccine decision. And we can give this vaccine without regard to any other vaccination. You can give other vaccines on the same day or sequentially over days, anything you want to do. The only, and Chris, I may be missing some here, but the only absolute contraindications that I could find are I had a severe allergic reaction to a previous dose, or I got myocarditis after a previous dose. All of these other things are not contraindications. I've had post-COVID syndrome. In fact, anecdotally, some people report they feel better. Their post-COVID syndrome gets better after they get vaccinated. MIS-C, you can vaccinate, but you have to wait 90 or more days, and you have to be recovered, and your cardiac function has to be back to normal. If you got passive antibody for prophylaxis, you have to wait 30 days. And if you got passive antibody for treatment of moderate disease as an outpatient, you wait 90 days. Pregnancy is not a contraindication, and breastfeeding is not a contraindication. If you do have questions about vaccination, we have initiated a vaccine clinic in our group, and we are seeing patients who have all sorts of questions about their vaccination. Either they're not up to date, they're immunocompromised, I don't want my vaccines, whatever. We are very happy to see your patients and help you navigate through this with the parents. So I was going to wind up here talking a little bit, and Chris, I have your other slides at the end of this, talking a little bit about the vaccine-associated myocarditis. These are the case definition criteria from CDC. This is from a series of patients, 139. The vast majority of them were adolescents, male. Most of them had no history of COVID or had a negative nucleocapsid antibody, which is a marker for prior infection. 94% had received Pfizer. These are the presenting symptoms: chest pain, fever, shortness of breath, headache, and you can see the rest. I learned a new term from Allie Black, who said something about LGE, and I was like, what is LGE? And she said, oh, you don't know? Lategadolinium enhancement. So that is what you see in these cases of myocarditis induced by the vaccine. And here you see the T2 weighted MRI, which shows inflammatory change in the myocardium. This happens after the second dose, pretty much. So these are data from Israel that show days since first dose, and it's the cumulative incidence of myocarditis after vaccination. And you can see there's sort of a low, steady slope until you hit day 21. And then within a few days, there's a sharp increase. So most of these cases occur 3, 4, 5 days after vaccination. There's a vaccine safety data link study that's ongoing, where the data were presented at the recent ACIP meeting. They compared people with myocarditis after vaccination to people who did not have myocarditis in the 22 to 42 days after vaccination. And again, what they found was most commonly this follows dose 2, and the excess cases per million was about 70. So that translates into an attributable risk of 1 in 14,000. So you can tell the parents of your adolescents there's a 1 in 14,000 chance of getting myocarditis from the vaccine. Good news is that virtually all cases are mild and they respond to NSAIDs. And then to answer your question about the 5 to 11-year-olds, there is no evidence at this point that those kids can get this vaccine-associated myocarditis. And these are data that were recently presented by CDC. So then just to end up on what we can do in terms of treatment of outpatients, I showed you the data that the Regeneron and the Lilly products do not work against Omicron. So Sotrovimab does work, albeit not as well. And the minimum criteria under the emergency use authorization is 12 and above and 40 kilos and above. So these are the general criteria for who should you think about giving monoclonal antibody. People who are 65 and older, people under 1 year of age, which we don't really have product now, and then BMI greater than 25 or greater than the 85th percentile. But those are the minimum criteria under the EUA. So you can't give it to people who don't meet any of these criteria. But who should you refer for monoclonal antibody treatment? In the Delta era and the era when Regeneron was working, we were happy to see anyone really who met these minimum criteria. And to be fair, most of them were not given drug. Most of them did well, and we were able to follow them serially to make sure the trajectory of their illness wasn't that bad. I think we're in it's a new ballpark now, and the Academy has released guidelines. When you're in a resource limited situation, which we are, I think the state gets, I forget if Joe Flynn may be able to tell us, but something like, I think we get 40 doses a week or something in the system, and all of that pretty much goes to the adults. We have some for children. I don't think you need to necessarily refer a kid whose BMI is in the 92nd percentile, or whose BMI is 26 or 27 or 28. I think that you can watch those kids, see them every day. We do telemedicine on this, so they're not bringing COVID into the office and exposing other children. And a lot of parents have an O2 monitor at home where they can go get one at Walgreens. So we feel pretty comfortable being able to monitor these kids without treating unless things start to go downhill. So maybe the criteria for referral should be a little higher, or the threshold should be. And there's actually a memo or letter that'll be coming out to providers that will specify those criteria and how you put in the referral. And we do monitor the referral queue all the time, even on the weekends. And we do see these kids on the weekend. So you don't have to call Chris Bryant on her cell phone to get one of these kids in for evaluation. There are antivirals, as you know. I won't go into it. We want to leave time for questions and answers. So right now we're using remdesivir in the hospital. We have not gone to outpatient remdesivir, which is an option for the adults. And we simply don't have the Paxlovid or the new Merck product as of yet. So I want to finish, and Chris, your slides are after this, but what is the end game for this pandemic, right? The end game is going to be endemicity. All the models predict that this virus is going to become endemic. It will not go away. We will not eliminate it. And it'll join the ranks of viruses that we see when people exchange aerosols and secretions with each other, which may be the wintertime, for example. But we will continue to see immune escape. I don't think it'll be at the level that we see with flu, where every year there's a different flu strain. And the reason I say that is there are evolutionary constraints on just how far this virus can go before it no longer is fit to spread in the community. Remember that this virus only has 30,000 RNA letters, and it only makes 13 proteins. So there's just so much it can evolve, right? And you've already seen with Omicron where the spike protein can evolve to evade our immune system and transmit extremely efficiently. But the virus has taken a hit in that evolution, in that it no longer is as dangerous and virulent as it was before. And then finally, vaccination is going to be our end game, where we can sort of live in peaceful harmony with this virus going forward. So Chris, I'll hand it back over to you.
Thanks, Gary. And you know what? It's fine to just mute the slides. I think let's move on to questions. And if there are specific questions about isolation guidance, we can come back to this. But we have a lot of questions about prophylaxis and vaccine, some submitted in advance and some through the Q&A. So let's talk for just a minute about vaccination. Many parents were anxiously awaiting vaccine for the less than 5-year-olds, and that's been delayed. So can you give us an idea of when we might have vaccine for younger kids? And given that now we're looking at 3 doses as a primary series in younger kids, you want to speculate on how many doses young kids might eventually need?
Yeah, that's a great question. And as you know, we are we are participating in the clinical trial of the Pfizer vaccine for 6 months to 11 years of age. So, what happened in this trial is they did a phase 1 study to pick the dose. And the dose had to balance the reactogenicity of the vaccine with its immunogenicity. So for the 11 to 12-year-old, or the 5 to 11s, it turned out that 10 micrograms was the sweet spot between those two things. For the under 5, 3 micrograms looked like it was the sweet spot. When the data were analyzed in terms of immunogenicity, and by the way, safety seemed to be fine for all of those doses. Under age 2, the immune response was not inferior to the response seen in the young adults. But in the 2, 3, and 4-year-olds, the antibody response was inferior, or was not non-inferior, is how they say it. And so I think we just miscalculated the sweet spot for that age group. To your point, we are evolving to where this is going to be a 3-dose series, okay? And even for grown-ups, it'll be a 3-dose series. So the clinical trial is going to be changing shortly, such that the younger kids are going to be getting that 3rd dose. And it's expected that within a few months, we will have the immunogenicity data from the 3-dose series. And by probably the 3rd quarter of this year, we should be able to have the EUA submitted. That's the best guess. Also in that protocol, which if it's not public knowledge, it will be soon, the interval to the 3rd dose will be less than 5 or 6 months for the younger kids.
Yeah, thank you for that. I think a lot of people are on pins and needles waiting for the vaccine for younger kids. So Gary, you made a really compelling argument for immunization in your presentation. But we know in Kentucky, at least when I looked about a week ago, less than 50% of the teenagers in Kentucky are immunized, and a startlingly low percent of kids 5 to 11 in our state. So what do you say to parents who might come to you and say, well, Omicron causes milder disease, many kids are asymptomatic or who have cold symptoms. Why do they need a vaccine? What do you counsel?
Oh boy. Well, Chris, I'm from Philadelphia. So I'm probably not the one you want to talk to them. I don't know. I would love to hear from some of our audience. There's 123 people on this conference call, and I would love to hear what some of the primary pediatricians in the community are saying to their parents to try to get them coming around to vaccination. I'm so struck by the dichotomy in the population. When we announced we were doing clinical trial, we had 1,400 families sign up to be in a study within the first couple of weeks. So much interest on the part of some people to embrace the science and get vaccinated. And then here, like you said, we have people who just simply don't want the vaccine. So there are all kinds of arguments to make. Over 3 billion people have been vaccinated on the planet Earth. And so far, it hasn't caused, those people, to my knowledge, are not being tracked by some mega computer somewhere at Microsoft. Their arms haven't become magnetic. None of them have died from being vaccinated. They've had sore arms. Some of them have been out of work for a day. I think the kids actually tolerate the vaccine better, so they may not even be out of school when they get vaccinated. And we have systems in place to find the rare side effects should they occur. And so far, all we have found is the myocarditis in the teenagers and the thrombocytopenia with thrombosis syndrome in people who got the Janssen vaccine. I mean, Chris, are you aware of any other, side effects from the vaccine that are significant?
I think those are the things to talk to parents about. You know, Gary, I agree. It would be very interesting to hear what pediatricians and nurse practitioners and family physicians are telling their patients. Sheridan Langford wrote in the chat that she says, I gave it to my own 5-year-old and I got it myself while pregnant and it went great. My daughter took it way better than I did.
Yeah, so the Sheridan is well-trained, because this is the teaching now, that forget the data, forget the studies, and hit them right in the heart. I gave this to my own children, or if I had children, I would, and my nieces and nephews have gotten it, and I would do it in a heartbeat. A lot of questions come up about, well, we don't know about the long-term side effects, right? And I was curious enough about this to email a couple of my mentors who wrote the book on vaccination and ask them, am I missing something, or are long-term side effects from vaccinations a common thing? Or is there even an example of a long-term consequence of vaccination other than not getting the disease? And the only thing anyone could come up with was rare cases of shingles that come up years later from the live zoster vaccine, which resulted from latency, established by the vaccine strain. That's it. There's no, in the history of vaccination, there's nothing else that shows up 6 months later.
Yeah, there are a lot of great responses in the chat, Gary. Heather Felton says, I gave it to my kids as soon as I could. I've taken care of your kids for years. I wouldn't recommend something dangerous. I strongly recommend vaccine. And I think we know that that matters to parents. A strong recommendation from a pediatrician or primary care provider.
And a personal narrative, that personal narrative.
Well, here's one, and it's very personal. Kelly Deatley, who is a family medicine physician, says that she has Kelly has kids that were in the Pfizer trial. One got placebo and one got real vaccine. The one who didn't get the vaccine is 11 and has post-COVID syndrome and still hasn't fully recovered from infection in August. And so Kelly shares that experience. So Kelly, best wishes that your child is better soon. When I'm talking to parents, I will acknowledge that, sure, lots of kids have mild or asymptomatic disease. Historically at Norton Children's, if we take 100 kids with COVID, 1 or 2 out of 100 will need to be hospitalized for COVID. That's a little bit higher than the national rates, actually, but you just don't know, right? And so that's pretty good odds, unless your child is the 1 or 2% that gets hospitalized. I think we should probably come back to some of these messages if we have time, because people are sharing valuable information. But I also wanted you to address, if you could, the idea, people who say, well, I've had COVID, I don't need the vaccine because I have natural immunity, I'm protected.
Yeah, it doesn't protect you from infection, and it might protect you from serious disease, but that won't protect you from becoming a vector of spreading it to other people. So, as much as we don't want to get sick, we also don't want to pick up the virus and give it to our parents or grandparents or immunocompromised people who can't be vaccinated. This takes a little bit of altruistic thinking, which people have trouble with these days.
Yes, totally agree with you. One more vaccine side effect question, and we've talked about it before. Parents of young girls are worried about infertility. Any truth to that idea that vaccine affects fertility?
Absolutely none. There was a recent paper that showed a very minor alteration in menstrual cycle related to vaccination, but I look at that as any kind of inflammatory stimulus, even if you get the flu or something, can affect the menstrual cycle, but absolutely no evidence. infertility or bad outcomes if given during pregnancy. In fact, there's evidence that COVID causes bad outcomes in pregnancy.
Yes, I think, we've actually seen some of that, firsthand at Norton Healthcare. We're seeing a lot of COVID positive moms right now. All right, so let's shift a little bit and talk about pre-exposure prophylaxis and post-exposure prophylaxis. Do you want to talk about, you've talked a bit about treatment with monoclonal antibodies, but in 2022, where are we with pre and post-exposure prophylaxis? And does vaccine work as post-exposure prophylaxis?
I haven't seen a study where post-exposure vaccination has been used or studied, but I don't think it would work. This is a little different than Hep B. So we know if you've been exposed to Hep B or rabies, let's say, post-exposure vaccination can prevent infection. And that's because those viruses have a long incubation period. So there's time for you to develop antibody to then prevent the infection or spread of the infection, but not so for COVID. So I don't think that's a good strategy. The monoclonal antibodies can be used for post-exposure prophylaxis, but right now, I don't think we should do that because number one, you can be vaccinated and you should have been vaccinated if you're a high-risk person, at least in the right age groups. And number two, there just isn't enough supply. I think I personally would rather have doses available for the bone marrow transplant patient who develops COVID and in order to prevent them from being hospitalized rather than, I've been exposed to COVID at, a dinner party or something. So can you give me a dose now so I don't get sick? I don't know. Don't you agree with that?
I agree. I think we don't have the supply of monoclonal antibody for post-exposure prophylaxis. Now there is Evusheld for pre-exposure prophylaxis.
Yeah, so long-acting monoclonal antibody.
Yep. And so it's given to someone who doesn't have COVID, who hasn't been exposed to COVID, who either is so immunocompromised, they're not going to respond to vaccine, or someone who has a true contraindication to vaccine. And Gary, as you pointed out, there are very few true contraindications to vaccine. My understanding is that Norton Healthcare has a limited supply of Evusheld. And if someone has a patient that they think might qualify, they can certainly reach out for a virtual visit. Again, the patient would need to be at least 12 years of age.
Yeah, Chris, a couple of things from the chat just I wanted to touch on. Susan Hafner said that she knows some people who developed debilitating tinnitus after vaccination, and that there's a physician at the Mayo Clinic, an ID physician actually, whom I know. It's Greg Poland, who's the editor, ironically, of the journal Vaccine, who did develop tinnitus after vaccination. So I don't know that this is confirmed as a causally related side effect. The last data that I've seen that looks at cases and controls does not show this. And of course, if millions of people, there are people who get tinnitus anyway, randomly. And if millions are getting vaccinated, there will be some people who develop tinnitus within days or weeks of getting vaccinated. So Susan, I honestly don't know if that's a real association or causal relationship. The other comment from Lauren Herman is it fair to say that the risk of myocarditis from COVID infection is much higher than after the vaccine? Yes, absolutely. Something like 1% of, is it 1% of hospitalized people with COVID have evidence of myocarditis? I think that's it. But yes, much more common after vaccination.
All right, lots of terrific comments in the chat. Michelle Ellisberg had a question about mechanism for newborns testing positive for COVID if the mom is positive. We talk about that for a minute. It's pretty uncommon. I think the literature is maybe 1 to 2% of infants born to mothers who have COVID are infected. Now, our routine practice is to test infants at 24 hours of age and 48 hours of age. In the beginning of the pandemic, we separated moms and babies. We don't usually do that anymore. We let mothers and babies room in. I think this is perinatal transmission, exposure of baby to mom at the time of birth or in the peripartum period for the most part. I think that the persistent thinking on this is that congenital infection is extremely rare if it happens. Is that still your understanding, Gary?
Yes.
Dr. Ellisberg notes that she had a patient just today, and I will say, yes, that is the fifth patient, the fifth neonatal patient we've had test positive. So within the first 2 days of life in the last 3 or 4 weeks. Now, just to put that in perspective, we had 15 over the course of the pandemic in our system. And we've seen a cluster here. I suspect that might be because so many women are testing positive right now. And so we're just seeing more babies.
Chris, I have a question for you about vaccination. Would you advise, I mean, pregnant women are supposed to be vaccinated and they're supposed to get the booster, but would you advise pregnant women to be vaccinated later in the pregnancy so that their babies would be born with higher levels of antibody?
You know, Gary, I don't think I would, because I think we know that pregnant women themselves are at risk for severe outcomes from COVID, admission to the ICU, mechanical ventilation, and death. And so I think we have to protect the pregnant women. We know there was an article this week that, yes, antibodies do cross into the breast milk. But I think in terms of timing to protect the infant, we don't know how best to do that. Maybe the best way to protect the infant is to protect the mother, because we know that when mothers develop severe COVID, their babies tend to not do as well.
Yeah. Michelle Ellisberg also asked, how do we convince families to get vaccinated when the vaccine doesn't prevent infection? I think we probably oversold vaccination in the beginning, and we should have really focused more on preventing disease than preventing infection. This is the sell we have with flu vaccine, right? It's only 40% effective in preventing flu, but it's nearly 100% effective in preventing death and hospitalization.
Great, thank you. Gary, I think we are right at the top of the hour. We are out of time. I'll just remind the group that Erin Fraser has a terrific podcast called Parenting with You. You and I have both been invited to be on that podcast. And one of Dr. Fraser's recent podcast addressed some of these questions about communicating with parents about vaccine and myocarditis. So we'll send that link so providers on the call can share that with their patients. McKenna, I think, there are so many good questions. Perhaps we can compile the ones we didn't get to and distribute answers to those. So.
Absolutely.
Thanks, Drs. Bryant and Marshall. This was a great discussion, great update, and we'll get those answers to everyone. I think there were over 170 people on the call, so that's great. So just a reminder to everyone, you'll receive a link to an evaluation for credit